Okay. Let's talk about a little bit, Claudia did, about IFPA. IFPA is the International Federation of Psoriasis Association, founded in 1971, and is the only global organization uniting all people living with psoriatic disease, regardless of where they live, what type of psoriasis they have, or how it impacts their lives, whatever color they have. And our members represent over 60 million people living with psoriatic disease. And together, we advocate for progress. And we're going to see how. We're formed by 56 countries and 63 members. That is, IFPA's regional and national membership is always growing. What do we do? Ensure the global representation, as I said, boost the voices of everyone living with psoriatic disease everywhere, lead the global advocacy, fight for the interests of people affected with psoriatic disease, demand representation on global health and development agendas, strengthen the member capacity. This is super important to try and end with the inequities that we can find everywhere. Share knowledge, we certainly do this, close the gap between knowledge and action, unleash the findings to trigger breakthroughs for people living with psoriatic disease, and unite stakeholders, super important. Build alliances with psoriatic disease stakeholders, transform global, regional, and national collaboration. As we said, we're the global advocacy voice, building upon our accomplishments. IFPA has achieved, and this is so important for everybody to remember this, IFPA achieved a major advocacy in 2014, a plan that started in 2009. For many years, we had tried WHO to put psoriasis in agenda, and every time the answer was, we do not have psoriasis in agenda. In 2009, I have to say, Kathleen was the principal brain of this change of strategy. And we started working, and we ended in 2014 when all UN member states unanimously committed to improve the lives of people living with psoriatic disease with the WHO 67.9 resolution on psoriasis, and then the report on psoriasis that came in 2016. So 10 years have passed. It's time to really implement and see what changes have we got. So this is how we are demanding progress. And I would say quicker progress. We have progress. We need quicker progress. World Psoriasis Day, it's our flagship. Everyone living with psoriatic disease deserves access to quality care, regardless of their income or geography. Treatments for psoriatic disease are better than they have ever been. Now we must ensure that good care is reaching the people everywhere, and join advocates from around the world to fight for access to care. And this is so important. I mean, science has gone so far up to now. And as we say, are we really using all the treatments that we have? No, we're not. And I would say anywhere in the world. We're not using everything that we need, or the access is very difficult. So World Psoriasis Day, 29th of October, everybody put a t-shirt on that day. What are we doing right now? The IFPA Forum is taking place in the hotel, and we speak up for psoriatic disease in Asia. What is happening in Asia? We did last year in Europe. Now we are here in Asia. And the forum unites stakeholders from across the psoriatic community to promote the regional action. And this is very important. Every time we talk about regions working together, each one of the regions, all the countries united in psoriasis are really working fantastically. The themes of the IFPA Forum Asia are access to care for people with psoriatic disease, addressing and managing the comorbidities, mental health of psoriatic disease, social and familial impact of psoriatic disease. And every time I think about the 65 million people with psoriasis, I say you have to do it by 4, which is a family, because it's not only the person that has psoriasis, it's also how it impacts the whole family, so much more. Okay, the Global Psoriasis Atlas. Give a clap there. When we got the resolution, we realized that not the resolution, but the report, in 2016, we realized that one of the things that WHO marked more was that there was no data. So we needed the data. And that is what we tried to put together with ILDS and IPC, and you're doing a marvelous job. The aim of the GPA is to understand the number of people around the world who have psoriasis and the care and treatment available to them. Epidemiology of psoriasis, understand and characterize the economy impact, recognize the comorbid disease burden, and improve the early diagnosis. And many studies are already being made on how important it is, the early diagnosis and the early good treatment of the psoriasis. This is a wheel that we presented in WHO when they finally said, we're going to put you an agenda. And we showed all the comorbidities, which is tremendous. It's the burden and the comorbidities. This, I mean, we have seen it already. I remember the first one, I think it was Georg Prinz, who presented the man with all the comorbidities and all the parts of the body that were affected by psoriasis. And we're going to talk just about some of them. This is Kathleen. This beautiful, my good friend, lovable Kathleen, excellent human being, super intelligent, super advocate, that couldn't come here because of anxiety that she got at the airport when her plane was canceled. So she's a 58-year-old woman, plague psoriasis and psoriatic arthritis, and comorbidities. There you have them all. That is Kathleen, and she keeps on working so much. And I have to say, I was really impacted when I saw the suicide ideation. I'm a very good friend of Kathleen, and I get chicken skin. I never heard her say that, and I'm sure she had it. I always asked myself, how could she, being so strong, with all the comorbidities and how much the burden is in her, how she could work so much. But she came up to the suicidal ideas. So, psoriatic disease, depression, and anxiety. And this we have to really think about it because, well, I mean, we should, if you had asked a person with psoriasis many years ago, it's kind of those phrases that come in, now we all talk about mental health. But mental health is one of the parts that strikes really the patient when they have psoriasis. What do we experience? Negative self-image, poor self-esteem, embarrassment and shame, stigma and rejection, social isolation, reduced social participation, discrimination, reduced work opportunities, anxiety, depression, and of course, you're going to have suicidal ideas. If you have all that, you're going to have suicidal ideas. And you will want a miracle, something that will change completely your life. This is Joel. He's one of our new ambassadors. And this is one of his phrases. After my baby was born, I had my life planned. I wanted to be the sporty dad, active dad. All of a sudden, I was using crutches that brought up all sorts of issues. I did not know who I was anymore. That is the real burden of psoriasis. And you can have this kind of phrases with every single person that has a severe to moderate psoriasis. Depression. These numbers are from before the Atlas, I think so. I would say, yeah, no. But, I mean, you have numbers. We can keep on looking. In Argentina, we made a study that we have 15 suicidal ideas in Argentina. Anxiety. There you have numbers. Malaysia, Singapore, 70%. Somebody has to wake up. Latin America. Look at the numbers in Latin America. Or you have to take a pill. Europe and United States. Endogenous. I have to say that when I learned about the endogenous and the exogenous inflammation, I said, finally, it's not my fault. Finally, it's not my fault. You know, that is one of the burdens that you feel that you have a psoriasis because it is your fault. So poor mental health causes flares, and flares cause poor mental health, and there we go round and round about. Is inflammation to blame? Psoriatic disease can cause depression, anxiety, and depression, anxiety can trigger a flare. inflammation-linked psoriatic disease, and poor mental health. Certain molecular mechanisms are shared between psoriatic disease and depression and anxiety, and certain treatments have been shown to improve both psoriatic disease and depression, anxiety in some patients. And I always say, if I get the correct treatment quickly, for sure, this is going to go down. For sure, this is going to go. So we have the global targets for the Comprehensive Mental Health Action Plan. This is from WHO, 2013-2030. This is what they aim to. Let's see what we get by 2030. 80% of the countries will have integrated mental health into primary health care. The global rate of suicide will be reduced by 1/3 by 2030. And 80% of countries will have a system placed for mental health and psychosocial preparedness for emergencies and or disasters by 2030. Remember, we're in 2023. Let's see what happens. What do we think are solutions? Early diagnosis and proper treatment of mental health conditions save lives. People are not a collection of symptoms. Dedicate time to talk about mental health and quality of life with your patients. It's very important. Invest in mental health. And I think it is so important, and we kind of go so quickly that we do not realize how much important it is. Psoriatic disease and diabetes, or comorbidities. Once again, I have to find out, this is very important. Once again, I have to find out about yet another comorbidity on Facebook that not one of my treating doctors has ever mentioned. Okay. This, we find it every single day, every single hour, every single minute. You know, wow, psoriatic arthritis. Arthritis is connected to psoriasis. Diabetes is connected to psoriasis. Depression is connected to psoriasis. Anxiety is connected to psoriasis. Uveitis is connected to psoriasis. Not ever once my doctor told me that. Not ever once. Let's start. And this comes right when my urine test showed excessive glucose, diabetes. Why wasn't a single treating doctor told me all the things can be susceptible to in the 51 years I have had this disease? This is very common, and this is very common. And I say it has to do also because not all dermatologists know about psoriatic disease. I mean, many dermatologists don't know about psoriatic disease. Even dermatologists, still we find dermatologists giving corticoid injections or oral ones. So diabetes, again, all over the world, different numbers. The link between psoriatic disease and diabetes, we made this with this when it was diabetes. How many years of the resolution of diabetes? That was about last year or the debate. Diabetes is caused by a combination of factors. Genetics and age-related factors associated to diabetes cannot be modified. Other factors, like having obesity or higher weight, being physically inactive, smoking, can be addressed, enabling behavioral changes. Some of the modifiable factors causing diabetes are common in people living with psoriatic disease and make psoriatic disease worse. Addressing risk factors, people living with psoriatic disease would bring the double benefit of improving psoriasis and preventing the insurgence of diabetes. What I see when we see this is, give us some more time with you. Give us some more time between the doctor and the patient, which is not easy. I know, it's the system that really makes it so difficult. Diabetes as a global challenge, definitely. WHO targets diabetes. 80% of people living with diabetes are diagnosed. 80% have good control of glycemia. 80% of people with diagnosed diabetes have good control of blood pressure. Why? Because they're well treated. Our solutions: perform routine screening for diabetes. I would say for all comorbidities of psoriasis. Inform people living with psoriatic disease about the importance of lifestyle changes, such as weight reduction and smoking cessation, to prevent diabetes and support them implementing those lifestyle changes. Increase the skills and capacity of healthcare professionals, especially in primary care. ensure continuity of care for psoriatic disease and its comorbid conditions in times of health emergencies. Now, hypertension and cardiovascular disease. It's funny, I am 70 years old, and I go back and I would have never thought that my skin had to do with my heart. Hypertension, numbers that we have from all over the world, you know them more. Cardiovascular disease, some less numbers that we have here. And remember when this came out, when Dr. Mehta brought this? Wow, that was fantastic. For the first time, we could show what inflammation meant. And here we see the increased inflammation in a person with psoriasis, inflammation in right knee joint surrounding muscle and ankle, throughout the liver, the wall of the aorta, and arteries in both thighs, and on the skin in the lower parts of the legs, consistent with inflammation of psoriasis. Cardiovascular disease is the main killer in the world. First, right there. In different countries, it depends. The second could be car accidents. People living with psoriatic disease have a higher risk of developing or having cardiovascular disease. Screen psoriatic patients for cardiovascular for early detection and intervention. But how many primary care and HCPs are aware and screen for comorbidities? Does the system let them do it? I can also ask. Here we make it a call to action. Shed light. More research on the burden of psoriatic disease and its comorbidities is needed everywhere in the world. I remember listening to the head of the non-communicable diseases, WHO, and she said, talking about deaths in chronic diseases, and she said, well, we're not doing well, the numbers are worse. I said, we're doing something wrong. If we keep on doing the things and we have those numbers, we're doing something wrong. Change the perception. This is so important. Psoriatic disease affects the whole body, inside and out. The vast majority of people living with psoriatic disease are not aware of its systemic nature and associated comorbidities. Over 80% of participants, and this is excellent work we did in about 5,000 patients with Novartis in psoriasis and beyond, over 80% of the participants were unaware of the increased risk of cardiovascular disease and diabetes associated with their psoriatic disease. Advance in the holistic care, comprehensive care of psoriatic disease must consider screening and prevention of comorbidities and mental health supports and prepare the health workforce. Enhance medical education on psoriatic disease in medical school and continuing medical education, especially at the primary care level. Now, IPC, and this is, I want to tell you that Kathleen said, thank you so much, and I say it also in the name of Kathleen and of IFPA, because IPC has been a champion change, shedding light, changing the perception, advance in the holistic care, and prepare the health workforce. So IPC is doing fantastic. Thank you very, very much.
Thank you, Silvia, very much for this great lecture. We have space for one question.
Thank Professor, and I'm from China, and I have one question. Well, I actually confused about the definition of comorbid disease of psoriasis. Is that include psoriatic arthritis too?
Yes.
So, yes.
Yes.
Okay.
That is why we changed the name of the psoriatic disease to include arthritis, because it was all the time kind of in two pathways, and we said, no, it's going to be one psoriatic disease, arthritis, and the comorbidities. Peter, you want to say something about that? Thank you.
Just very modest just to give another sound. That is, when we speak about psoriasis, it is the disease, and it implies actually that it is beyond the skin. The word psoriatic disease, we can make the same as the diabetic disease, on one of your slides, you could also have said, but your talk was excellent, so please, yeah, the psoriatic disease, diabetic disease, I think it is much more comprehensive and direct when we just speak about psoriasis.
Oh, thank you. Yes, I
Thank
think-
you. Thank you.
Thank you.